Good morning, everyone from Italy, and thank you for the invitation. And today, my task is to speak to you about right ventricular abnormalities as seen on cardiac magnetic resonance. So, why are they important? Well, because certain conditions can pose a risk of sudden cardiac death for your patient, and in some cases, they can be diagnosed through participation, pre-participation sport screening. So here you have the well-known arrhythmogenic cardiomyopathy diagnostic criteria written by Corrado in 2020, and here you can see criteria of RV phenotype, the one we will treat today, and LV phenotype and biventricular. So about right ventricular phenotype, we have some diagnostic criteria relying on imaging, and cardiac magnetic resonance is really important to help you in this context. But there are some mimics of arrhythmogenic right ventricular cardiomyopathy. How? Because right ventricle could be not normal, but not necessarily affected by RVC. When there are conditions such as cardiac displacement, like pectus excavatum or carinatum or scoliosis, then when there is some right ventricular overload in terms of pressure or volume, like ASD or pulmonary hypertension or tricuspid regurgitation, and you can find RV scarring, which is not arrhythmogenic right ventricular cardiomyopathy, but also myocarditis, sarcoidosis, or inferior myocardial infarct. So why is MRI helpful? MRI is helpful because instead of echo, you can have a wonderful geometrical assessment of the right ventricle. As you can see in those short axes, you can cover the full ventricle perfectly. And there are no geometric assumptions like in ultrasounds. When you go to measure your volume and function, there are no geometric assumptions. And moreover, you can assess pulmonary flow and arterial flow as well, of course, in order to recheck your volumes and in order to see whether there are intracardiac shunts. So just in this case, you can see an ASD, so an atrial septal defect at this level, it's ostium secundum. And with the cardiac MRI, we also could measure the QPQS, which is 1.2. So a left to right shunt, but really mild. So 2 words about gadolinium. Gadolinium is a contrast agent that we use in cardiac magnetic resonance, and it has an extracellular distribution, which means that when you have a scar, you will find a lot of gadolinium, so a lot of contrast within the myocardium. And this is an example in which you can see this right ventricle in MRI with all this scar. White is dead in this case, and this is a right ventricular arrhythmogenic cardiomyopathy as well. So once again, okay, same here. And cardiac magnetic resonance really helps the diagnosis of arrhythmogenic right ventricular cardiomyopathy. Here you can see the MRI of the patient, and this is the biopsy. And from the biopsy, you can see the whole amount of fibrosis of the RV, which we could identify in the images that we had as well. So how can we distinguish different degrees of right ventricular dilatation and dysfunction? Are they all arrhythmogenic cardiomyopathy? No, they are not. So a very, very important issue is assessing not the images only, but also ECG and clinical history. So these are two RBC cases. I'll show you the clinical history. This is the first patient. You can see abnormal ECG with abnormal ECG in V1, V2, V3. And this is the Cine imaging. And you can see the right ventricle is not properly contracting. And this is the other patient, same thing here, negative T waves from lead 1 to 4 in precordial leads, and right ventricle is not, has a funny shape. You can see it, it's bulging in its free wall. So this is a clinical case, 16-year-old with a history of sudden cardiac death, and he had palpitation during exercise. So he performed an ECG alter, and he had premature ventricular beats with left bundle branch morphology. And at rest ECG, he had an incomplete right bundle branch, block of bundle. And echocardiography showed dilatation of the RBE. So he performed a CMR to exclude RVC. This is the echo image. So you can see it's a parasternal short axis view, basal. So big right ventricle and flattening of intraventricular septum. And this is the ECG. And then you can see the CMR picture. So ventricle is dilated, but it's contracting properly. And we did find no LGE, so no gadolinium, no contrast, no fibrosis. And finally, during the scan, we could see a dilatation of the azygos vein. And he receives, it was a case of partial anomalous right pulmonary venous drainage in azygos. So this is another similar case with a superior pulmonary vein in SVC. And this is the first case with follow-up after surgery. He underwent correction of the defect, and this is the right ventricle, which is smaller than the left one, if you see at the follow-up, whereas before the intervention, it was bigger. So let's go to another clinical case. 17 years old, soccer player, palpitation after exercise, ECG incomplete right bundle branch block, mild biventricular dilatation, compatible with athlete's heart. So coronary arteries were okay, also at ultrasound. No history of myocarditis. Those are the volumes. So you can see right ventricle and left ventricle have different stroke volume. Why? Are there any regurgitation or shunts? No regurgitation. So he underwent transesophageal echocardiography and had no anomalies pulmonary venous drainage. So he had a detraining of 3-5 months and repeat CMR. And what we found out was that this patient actually had a normal heart. So previous stroke volume had a wrong assessment, and this could happen. So what we always should do in CMR to avoid this kind of mistakes is checking with phase contrast images, the one I told you before, to check for aortic and pulmonary flow in a way that is independent from your anatomic measurements. So you can't go wrong, actually. Stroke volume is always really reliable with this technique. So you can check it with the volume you have from the cine images. So this was a case of uncorrected post-processing. Patient was fine, okay? This is a third clinical case, and a female, 39 years old, with palpitation, and she had a lot of prematuro ventricular beats with left bundle branch block morphology, and CMR showed a bulging of the subtricuspid region of the CMR. I show you. Okay, once again, okay, this is the bulging, okay. And she was defined as probably affected by RBC, but later she had a follow-up, still bulging of subtricuspid region, but we know dysfunction. So you can see the images. There is the bulging, okay, but no dilatation. And 5 years later, the MRI was stable. So she only had this kind of bulging with ectopic beats, ventricular ectopic beats, but she had an idiopathic RVOT tachycardia, because the follow-up is also really, really important. Male, 21 years old with palpitation. You can pose the diagnosis from the beginning. You can see he has a real diagnosis of excavatum pectum excavatum. And you can see how the anterior wall of the chest is pressing the right ventricle, and this can cause arrhythmia as well. So this is HEG, which is, we can't say it's normal as well, but finally he had a thoracic deformity which explains the arrhythmias. This is the most common report we found in MRI for athletes, which is athlete's heart. So key points are biventricular dilatation with balanced ventricle, left and right, no chin abnormalities, and if still in doubt, you should reevaluate after the training. This is a sixth case, with really, really important, but you can see chin is really helpful in this case. So there is a systolic D shape of the interventricular septum, and the right ventricle is dilated, such as pulmonary hypertension, and the ECG as well is really typical of pulmonary hypertension with the right ventricular overload. So this was not an RBC as well. So we should differentiate RBC from normal heart or other phenocopies like chest deformity, like idiopathic arrhythmias, like pulmonary hypertension, or ASD, or pulmonary venous drainage anomalies. So finally, what we should look at with our CMR. So chin images are really important because you can see all the bulging or akinesia or regional RV wall abnormalities, and you can see if in a T1 weighted, so when we look to the fat, if there is any fat tissue within the myocardium, which should not be there, of course, and also LGE, so gadolinium, so fibrosis of the wall. So this is the same case of RBC. And then I remember you that we can have these beautiful images that are very difficult to get with the ultrasound. For genetic impairment, CMR is wonderful. You can see this infundibulary bulging, how well is displaced, and also here apical bulging. Okay, and once again, this is a subtricuspid bulging with tissue fibrofatty replacement, and these are the arrhythmias that this patient had. So this is an RBC, And same thing here, gadolinium in the same region of the akinesia of the right ventricular wall. Still the same case, okay, with right ventricular dilatation and bulging of all this tricuspid region. LGE, this is the picture I showed you before, but this is that patient, and LGE, it's really extensive. So finally, RVC or normal variant or pathologic variant but not RVC, you should keep a clinical approach. So polyparametric diagnosis, patient history, ECG, kind of arrhythmias, and I really, really recommend you to perform an on-site CMR scan protocol. So Cine of the RV, T1 weighted for fat, LGE, but to be assessed while scanning, because every patient is different and every right ventricle could look different. Thank you very much for your attention.